Next, we will talk about multiple sclerosis syndromes. First, we will talk about Baloch disease, otherwise known as concentric sclerosis. This is an acute monophasic process. Histologically, what you see is alternating concentric regions of demyelination in normal brain. It is thought to be a variant of multiple sclerosis, and on T2-weighted imaging, you see concentric onion bulb, hyperintense, isointense, hypointense concentric rings. It commonly has peripheral diffusion restriction and enhancement. Additional multiple sclerosis syndromes include diffuse sclerosis or shoulder disease and Marburg variant. Diffuse sclerosis is an acute, rapidly progressive form of multiple sclerosis. It is symmetric, large areas of demyelination that is well circumscribed, often involving centrum, semiovale, and occipital lobes. It usually occurs in childhood and rarely occurs after the age of 40 years. Marburg variant is characterized by repeated relapses with rapidly accumulating disability. On imaging, what you see is multifocal white matter T2 hyperintensities with confluence to larger areas and extensive dissemination. Here is a case for review, 31-year-old female with right-sided numbness or weakness. Here you see a concentric region of T2 hyperintensity and hypointensity. And you see areas of diffusion restriction peripherally, as well as mild enhancement, again, which is an incomplete ring enhancement. There isn't much mass effect corresponding to this lesion. And this is a very classic imaging appearance with concentric ring on T2-weighted imaging with Baloch concentric sclerosis. Additionally, you can see optic neuritis with multiple sclerosis. The term optic neuritis usually refers to infectious, especially viral, inflammatory, or demyelinating causes. Inflammatory causes include sarcoidosis, pseudotumor, or lupus, and demyelinating disorders associated with optic neuritis include multiple sclerosis, ADEM, NMO, as well as clinically isolated syndrome and idiopathic isolated optic neuritis. There's also something called clinically isolated syndrome. This is when the patient only has a single episode suggesting the diagnosis of multiple sclerosis. 80% of these patients with clinically isolated syndrome at 15 years will meet the diagnostic criteria for multiple sclerosis if they have positive MRI findings. However, only 20% will have multiple sclerosis at 15 years if they have a normal MRI at diagnosis. Of these patients, 77% of patients presenting with isolated brainstem syndrome have asymptomatic supratentorial white matter abnormalities. Progression to multiple sclerosis occurs in 57% of patients with isolated brainstem syndrome and 42% with isolated spinal cord syndrome. Next, we will discuss a term called radiologically isolated syndrome. This occurs when 3 of the 4 McDonald criteria for multiple sclerosis is met. Specifically, at least 1 gadolinium-enhancing lesion or 9 T2 hyperintense lesions, at least 1 infratentorial lesion, at least 1 juxtacortical lesion, and at least 3 periventricular lesions. These patients clinically have not had a multiple sclerosis episode, however, but 1/3 will progress to multiple sclerosis in 3 years, and it's an even higher rate if there are enhancing plaques present. So a little bit in terms of distinguishing radiologically isolated syndrome versus clinically isolated syndrome. With clinically isolated syndrome, there is 1 attack and 1 clinically objective lesion, with 20% progressing to multiple sclerosis if there are no MRI findings, and 80% progressing to multiple sclerosis if MRI criteria are met in 15 years. However, if optic neuritis is the first symptom, 50% progress to multiple sclerosis. With radiologically isolated syndrome, you have lesions very typical of multiple sclerosis, specifically ovoid, well-circumscribed lesions, which may or may not have involvement of the corpus callosum, with T2 hyperintense lesions greater than 3 millimeters, fulfilling McDonald's criteria, specifically the McDonald's criteria upon the MRI section. In addition, the lesions must be inconsistent with a vascular pattern and not explained by other entities. Therefore, if the patient has history of drug abuse, toxic exposure, or other medical condition that can cause similar lesions, it would not be characteristic of a radiologically isolated syndrome. And this must not be better accounted for other disease processes. With radiologically isolated syndrome, 33% progress to MS in 3 years, and 80% of enhancing foci are coexistent.